Hello, everybody.
Hello.
Hello. Mark's here. Laura?
Here.
Here.
All right. Well, I wanted to welcome everybody to our Fall Voice webinar. We're really excited you could attend and online. This has been a really great venue for Fall Voice to provide another educational opportunity for everybody. Today's topic is benign mid-membranous vocal fold lesions. And I'd like to introduce, I have sort of a virtual panel of sorts here. And first we have Sarah Schneider, who's a speech and language pathologist at UC San Francisco. Say hi to the crowd.
Hello. I hear my team screaming in the background.
Woo. We have Mark Corey, who's a laryngologist at Mount Sinai in New York. Mark?
Hi, everybody. My team's gone home.
And Laura Dominguez, who's also a laryngologist at San Antonio, who's going to be fielding questions for us today. Are you here, Laura?
Hi.
Hi. The disembodied voice of Laura Dominguez. Well, all right. So I would be remiss before we started if I didn't point out that the actual Fall Voice Conference will be going on October 12th through 14th this year in Washington, D.C. Should be a fabulous event. If you have not been before, I would highly suggest you go this year. Also, if you are planning on submitting an abstract, the deadline is coming up this next Monday, the 15th. So please get those in. So the topic is benign mid-membranous vocal fold lesions. And as you can see from the chart here, there are a variety of sizes and shapes of vocal fold lesions of the mid-membranous region. And there are many names to go with these. There's nodule, nodules, polyp, cyst, pseudocyst, fibrous mass. There are a number of different names that are associated with different lesions, and there can be some confusion because things can look somewhat similar. But it's a little bit like the Brady Bunch, where there are definitely things that look similar if you look at the chart, but each entity has its distinct characteristics. And if you put everything together, you can come up with a name for most lesions. Had to throw the Brady Bunch in there. There was debate on how long I would go here before I use the word nomenclature, and right out of the bat, I'm gonna bring it out there. So the problem with, as I mentioned before, with vocal fold lesions, benign lesions, is we can't agree what to call them. And this has been a problem for a long time. And the issue is, if you biopsy most vocal fold lesions, and Mark Corey has a beautiful paper on this, if you biopsy nodules or a polyp, when you look at it under the microscope with H&E stains, they look very similar. So how do we name these? And so Clark Rosen set about to do this, and there's a paper I think that myself and Mark is on, and Clark sort of brought this forward, looking at how can we define vocal fold lesions. And there's four things that are looked at. There's the morphology of the lesion, the shape of it, the stroboscopic features of the lesions, response to voice therapy, and then if the patient goes to the operating room, the intraoperative findings of the lesion. And based on these things, came up with a system that had 9 lesions, which sounds kind of daunting. But this is from a chart from a subsequent article by Dr. Rosen. And really, if you look on the left-hand side, and we'll get to the definitions later, vocal fold nodules, which are bilateral lesions, polyps and cysts are probably the most common things you're going to see. There are other things, fibrous mass, reactive lesion, pseudocyst, not quite as common, and we're going to focus on the most common things here. There's no way we can cover all of these in one webinar, so we're going to go with hopefully the meat and potatoes for everybody. So let's start with vocal fold nodules. Now, again, we could debate what are nodules and what are not. So we're gonna show you a couple of, or an example. So nodules are phonotraumatic lesions. They occur in the mid-membranous vocal fold, which is what we're talking about. That's where the maximal collisional force is between the vocal folds during vibration. They don't occur exclusively in females, but it's not far off from that. Mostly females in the teenage all the way up to really perimenopausal. I used to say no, I had not seen nodules in somebody above the age of 50, but I have subsequently seen that. So it's fairly rare, but usually it's in teenagers to about 45. I've seen it in countertenors. Mark, I don't know if you've ever seen it, nodules in a man, or Sarah. Are we there?
Yes, I've seen nodules in men and trans women too.
Oh, interesting. All right. Well, and the reason for nodules, the predominance of nodules in females, really, there are a number of factors you could talk about, but I think to boil it down to its essentials is it's all about math. And the average fundamental frequency of a woman's about 225 hertz, and a man around 125 hertz. So for every second of phonation, women are going to have roughly twice as many collisions between the vocal folds. So a repetitive stress injury like this would be expected to be more common in females. By definition, that's why you see the S has been outlined with, in yellow. Nodules are bilateral. There's really, in this system of nomenclature, there's no such thing as a nodule. It's only nodules. They're bilateral lesions, fairly symmetric on stroboscopy, fairly minimum stiffness. And they respond well to voice therapy. And what do I mean by that? I mean complete or near complete resolution. This would be a classic picture of vocal fold nodules, fairly small, mid-membranous, fairly symmetric. But that's just a still shot. So I have a case, and I don't want to suggest these are going to be nodules. It could be entirely coincidental. But case one is a 23-year-old female with several years history of dysphonia worsening over the past 6 to 12 months. And she describes her voice as a raspy quality and has difficulties with vocal fatigue and sometimes odynophonia at the end of the day. She is a graduate student and socially very active, and really no change in her vocal demands recently. Her VHI 10 is 17. Sarah, before I even show you this video, let's just say you're in your clinic and you pick up this chart and you read this much of a history.
I would expect nodules.
You would expect nodules, right, Mark? Do you agree?
Yes, I would agree with that.
So you already have the diagnosis. Do we need to show the video?
Please.
Okay,
Yes.
show it anyway. So this is our patient.
The rainbow is a division of white light into many beautiful colors. These take the shape of a long, round arch with its path high above and its two ends apparently beyond the horizon.
Sarah, can you, as my TV goes off here on the
Yep.
World Wrestling, WrestleMania,
Oh, WWF.
can you just describe her voice or distinctive characteristics about her voice just listening to that sample?
I would say she has some mild roughness. She does not seem to be speaking with very much airflow, and her resonance is kind of posterior in her throat.
Okay, very good. So we'll just show the video portion of this.
As long as you can hold it up.
Okay, now that's a single pitch, and I know Mark likes a variety of pitches, and we would normally do that, but for the purposes of this talk. So that's your video. Go ahead.
Is she stiff in the upper pitches, Blake?
I'm sorry?
Are her vocal folds stiff in the upper pitches?
Not very much, no.
Okay.
So questions, I'm going to start with you, Sarah.
Okay.
Questions for Sarah first. So and I didn't give the full history, and so I mean, obviously we don't want to give an exhaustive history, but when you're seeing a patient who has bilateral mid-membranous vocal lesions that appear to be phonotraumatic, such as this patient, are there any parts of the history you really want to tease out, the most important things to you before you start therapy? It's a relatively open-ended question here for you.
Well, I think the biggest.
Sarah's frozen. Can anybody hear?
Can everybody hear me?
Yes, go ahead.
I would try to tease out a little bit more clarity on when the voice change happened so that I could try to identify what the offending behaviors are. Just to help guide a little bit with vocal hygiene, because I feel like telling these patients just to stop everything just doesn't work. Okay. So really trying to hone in on specific vocal hygiene things to change is one of the main things.
Okay, and it started when she started teaching in graduate school. She was a teaching assistant. That's when it got worse. All right.
Okay.
Are these consistent with nodules? You don't have to necessarily render a diagnosis, but from what you've seen, do you think those are consistent with nodules?
Yes.
Okay.
They're bilateral and symmetric, which I think in the vibratory parameters are pretty much intact.
Okay.
Yeah.
And so what's your approach to therapy, just in a very general sense, when you take these patients on, just in terms of indirect and direct? What would be a typical course?
So I would probably, a typical course as far as duration is I'd probably want to start with about 4 sessions of therapy with somebody like her and do one time every other week. In the early part of therapy, we'd focus on the indirect piece of it, talking about like what are the offending behaviors and what can she cut back on based on her requirements at work and school.
Okay.
And then primarily I would focus on the direct piece of it, just making sure that we're trying to improve vocal efficiency. So hopefully, one, her symptoms improve, and secondarily, hopefully we can affect some change and promote healing of the lesions.
Okay. So, and you mentioned 4 sessions. How many do you think you typically need on a patient like this, just exactly like this patient?
If she is into therapy, 4 sessions.
Way into therapy.
4 sessions.
Okay, good deal. Mark, I wouldn't want to leave you out. Are these nodules?
So they are bilateral symmetric lesions at the junction of the anterior and middle third.
Mm-hmm.
You could call them nodules. They seemed a little bit stiffer than I would like. So they might be approaching submucosal or intramucosal fibrous masses, subepithelial fibrous masses.
Okay. Why are you a contrarian? That's my next question.
I think I'm a realist, not a contrarian. I try to look at all sides, and I try and point out, you know, when is it appropriate to make a mountain out of a molehill? That's what we're doing here, right?
Yeah, absolutely.
And what is my role in treatment of these patients?
Right. Because you would say in a patient like this, the way I look at it is the speech pathologist is the most important member of this team. And we see all our patients together, and I know you guys do as well. Physician and speech pathologist side by side, we evaluate the patients together. And I think as Mark mentioned before, we'll usually say, okay, this is definitely a patient who's a therapy candidate. What point is your role in this patient in taking care of it?
To help explain the physiology of how these lesions got there, and to explain why, because of that physiology of how they got there, they're not a surgical candidate.
Okay.
And
Do you think there's any reason, do you think cofactors like reflux and allergies can play a part in nodules persistence, or do you think it's important to treat these? Because I've thought of this in 2 different ways. I mean, before I would treat almost everybody for this, and lately it seems like not nearly as much.
so I'd ask them about histories of reflux and allergies. And if they had a significant complaints related to them, I'd treat them. But if they didn't, I was so fixated on the nodules, I forgot to look at the esophageal inlet and the area epiglottic folds to see if there was edema or anything of that nature. But if she said, you know, I don't experience reflux, this is not silent reflux.
Yeah, I agree. Would you ever recommend surgery for somebody with lesions like that? If they had a trial of good therapy, they get it, as our speech pathologists will often say, they get it, they work hard. Would you ever operate on nodules?
So there's a school of thought to say that they get it, they work hard, but they can't do it because the nodules are there. So you have to give them a clean slate. I don't believe that school of thought, but there are others who do.
Okay. This is her after, I think she had 6 to 8 sessions of voice therapy.
The rainbow is a division of white light into many beautiful colors. These take the shape of a long round arch with its path high above and its 2 ends apparently beyond the horizon.
Already she's much more easy to listen to, more inspiring, right? All the things that you pointed out, I think she's fairly corrected. That is some quality speech pathologist work right there. That is beautiful.
Yeah, that's gorgeous.
And you've just confirmed that they're nodules, right? Because they resolved or improved with therapy.
That's exactly right. And if you follow that nomenclature algorithm, that's exactly right. If they resolve, you know, considerably, the patient becomes asymptomatic or has minimal symptomatology. then yes, those were probably nodules. And that's kind of how that works. But it brings up an interesting question. And I think a lot of times we'll see patients who have more prominent nodules with that to start out with. And then after therapy, they'll be much smaller. The patient's asymptomatic as far as they're concerned. They have no limitations in their either speaking or singing voice. And yet there's still something there. And we still say, well, those were nodules, you know, they resolved whatever percentage you want to put on it. And I still feel that's the same diagnosis. They don't have to go away completely, I guess is what I'm saying. And some people will fixate, they'll see it on the screen, there's still something there, and they get fixated on that. And it's important to remind them, you know, it's the function that's the most important. And that's sometimes the worst thing about having big monitors in your room, the clinic, because the patients will fixate on stuff sometimes.
Well, I think in response to that, Blake, I will counsel patients. Your voice is sounding better. We're going to look at your vocal folds in you know, a couple weeks. Even if everything's not gone, it doesn't mean that you're not doing better.
Yeah.
So sometimes I think depending on the person, I might bring that up in a session.
So I always mention at the start that, you know, these don't have to go away. You just have to be happy with your voice.
Mm-hmm.
And if you get happy with your voice, it doesn't matter what your vocal folds look like.
Absolutely. All right. Very good. Questions from the webinar audience? Laura, did anything come through that's piqued your interest?
Yes, there was one good question asking about, well, so far, one good question, asking about the role of intralesional steroid injections for these types of patients.
I mean, I can speak to that a little bit. I mean, I don't do it very often because these are therapy patients and they have to have good voice therapy to resolve, but I have used it to kickstart some people who had maybe bigger nodules, maybe that were a little more stiff. I've done that on the front end before they start their therapy, and I don't know that it's made a difference. Makes me feel better. So it'd be to kickstart, but as a primary treatment, I don't think that's going to be effective. Mark, do you have an opinion?
Yeah, you know, I've never done it. I've always worked with such talented speech pathologists that I haven't had to.
Yeah, good point. I've used it also to get somebody through the year. Like I've had school teachers that had nodules and they were doing therapy, but they were kind of crippled and trying to get through the year. And I've done it before in that instance. And we like to think it's helpful. I couldn't swear that it did the trick, but it seemed to help.
So I am a little worried about atrophy and inducing some little bit of scar or trauma from the injection needle.
I think it's a valid point.
Atrophy, like skin atrophy, like thinning, or muscle atrophy?
Skin. I think with the 29 or 27 gauge needle that you can pass through the flexible scope, it's a little bit difficult to get into the muscle unless you really jab it in, but you are in the epithelium, the mucosa rather. You're still in the subepithelium, so I worry about inducing atrophy there. Okay.
Moving on. Thank you very much, team. Very nicely done. Vocal fold polyp was the next one I wanted to talk about. Generally unilateral. You can see them. You can definitely see them bilateral. I have, but more often than not unilateral. They're exophytic, which means they extend beyond the free edge of the vocal fold. They can be hemorrhagic. Classically, the pictures you'll see are hemorrhagic, but they can be sort of semi-translucent, almost look like a cyst. Usually, mucosal wave is not impaired to a great extent. Except for the small ones, the larger polyps tend not to respond to voice therapy with resolution. And if you take them to surgery, they tend to have a gelatinous or disorganized material in the subepithelial space, and the epithelium over the polyp is typically atrophic. These would just be two still shots of polyps. Again, you see the hemorrhagic nature. There's one that's major league there on your right. That's probably 13 millimeters in size. Probably won't go away with voice therapy. You think, Sarah?
I don't want that person in therapy.
So the treatment of polyps, and this is just sort of what's worked for me. I think small polyps, there's a lot on the table that can work. And by I mean 2-3 millimeter polyps or smaller. You can observe them. If the patient doesn't want anything done, I like to do serial stroboscopies. I mean, there's always that rare patient that morphologically looks like a polyp and ends up being a spindle cell carcinoma. That's very rare, but you can see it. They should be followed if we're going to observe it. Voice therapy, I think, can work very well for small polyps. Pulse KTP laser in the office or OR can be used. Corticosteroid injection I've used, again, not as a a treatment that's going to result in complete resolution, but something maybe to get them through therapy or until the time they need their surgery. Anything larger than that, I think, tends to need microflap surgery. Now, I'm not suggesting that these patients shouldn't have voice therapy, the larger polyps. I'm just saying that's not your primary treatment, in my opinion. So I'm going to show you a case. Could be a polyp, maybe it's not. 46-year-old male with several months history of dysphonia. It's been gradually progressive, and he can't remember the exact onset of the problem. And he works as a human resources supervisor. He's a huge San Antonio Spurs fan. I just realized I'm not watching the game, which just started at 7. So I'll miss a little bit of that. So he likes to go to sporting events. He likes to yell a lot. His VHI 10 is 24. So I'm going to play you about 8 seconds of this video because there's something that happens after that I can't let you see. So watch carefully. I'll play it again. Hold on, let me come back here. Get a little still shot there. And I'm sorry, the Pedial was just killing me that day. Any observations about that, Mark?
Yes. So we all play with laryngeal closure forces and airflow to produce voice. And I think it's always a continuum. And you can see the obvious lesion on his right vocal fold. And then on his left vocal fold, there's a little petechiae, or very much smaller, but very similar lesion opposite it. So I think of this patient as an inefficient chronic voice user who speaks too often with too much pressure in his larynx, leading to epithelial slough and healing by secondary intention. And on the right side, he's developed what is probably a larger vascularized polyp, and on the left side, he has a very small vascularized polyp.
Excellent. All right. So would you recommend surgery as a first-line treatment for this, Mark? I know your history is kind of sketchy, but just in general.
So, the answer is probably not. Because he's got some bilateral nature to this, I would want him to have at least 2 or 3 voice therapy sessions to really understand physiology, to understand indirect and direct voice therapy, because I don't think he's using good flow phonation even in his speaking voice. I mean, I don't know that we heard the speaking voice, right? We went straight to video.
The time, yeah.
So I'm concerned that if I do surgery on this, he's going to recur because he's going to go back to those old habits. And there's some bilaterality to this. So in my hands, this would not be a first-line surgery candidate.
All right.
I mean, I can see the other side. Somebody else would say we got to shrink that right side down so he can learn to use it more efficiently.
I'm trying to avoid open-ended questions with you just in case you went over. But actually, you made some superb points, so thank you very much. And maybe I didn't completely think through that as much as you did. That was fantastic. If it's used as a primary treatment, as you suggested, how long would you go before recommending, okay, let's go and pull the trigger and let's go ahead and do surgery on this patient? How many?
So I think once patients get it,
right?
If they get it within 6 weeks of getting it, the lesions are going to respond significantly. And if they don't respond significantly at 6 weeks, then I'd go ahead and pull the trigger for surgery.
Okay. That seems. Sarah, do you have any? I got some questions for you. Would you approach this particular patient, just from what little you know, any differently than a nodules patient?
Not really.
Okay.
Yeah, I don't think the diagnosis always guides our exact approach and treatment. I think, yes, he's going to need indirect therapy, he's going to need direct therapy, but I think we have to assess how the patient's compensating for the lesion, how they're using airflow, resonance, strain, and a lesion on the vocal fold is a lesion on the vocal fold. We have to figure out what the patient's doing with it.
All right.
To some extent. I don't want to oversimplify.
Okay. No, I understand. So this is him again. And this gentleman, everything was on the table. I agree completely with you. He saw our speech and language pathologist, and the options were presented: voice therapy, KTP in clinic, observation. So he went through all those, and he'd seen Jill, our fantastic speech pathologist. and he decided he wanted to, I think he came in knowing he was interested in the KTP laser in clinic. So, and I don't offer it for everybody. This is his KTP procedure.
Was it smaller?
What's that?
It
I think
looks
smaller.
That's to say, maybe it was on going away. I'm glad I got to it in time so I could look like a hero.
so. This how long between this and the original?
Probably no
Video.
more than a week or two, Mark. I get them signed up quickly before they go away. So this is post procedure. So yeah, and I think it does underscore, you know, that gentleman may have gotten better without anything, just voice therapy, doing absolutely nothing. And there'd be nothing wrong with just observing that. And probably if I didn't have the KTP laser, that's exactly what I would have done, voice therapy and observation. So yet another treatment. There are clearly bigger ones, and I just throw this in because I know our speech and language pathologists don't often get to see sort of intraoperative stuff, what we do in the OR. And just sort of an example of what I'm not going to show the whole thing, just part of what a microlaryngeal phonomicrosurgical procedure would look like for a polyp, and this is just basically showing dissecting it away from the epithelium. So just so you know, we do go to the ORs for these. Or is there a question from the webinar audience, Laura, that you can share with us?
Yes, we have a question from Justin who would like to know if the appearance of the polyp, besides size, meaning more whether it's translucent or hyaline in nature, does that indicate their likelihood of benefit from voice therapy?
Good question. What do you? I don't think so. I've seen both respond. What do you guys think?
I agree.
I agree. I've seen very vascularized polyps respond, and I've seen translucent polyps respond.
Okay.
I think I have a tendency to think that the softer the polyp, the better it's going to respond, but they both seem to.
Yeah. Okay.
Maybe it's more about size.
All right. Vocal fold cysts. Almost always unilateral. I don't know that I've ever seen bilateral cysts. Maybe epidermal inclusion cysts, yes, but mucus retention, no. You can have, there's two basic forms. There's epidermal inclusion cyst, which is generally on the superior surface of the vocal fold, sometimes extends to the free edge. And then mucus retention, which originates in the infraglottis, right? Because the squamous mucosa does not have glandular tissue. So it originates infraglottically and can expand up towards the free edge. Stroboscopic findings depend on the location, but as a general rule, mucosal wave is reduced or it's absent due to the sort of, I'll show you a video later, sort of the adhesive nature of cysts. Usually does not resolve with voice therapy or voice rest. And if these patients go to surgery, that's really where you discover it's a cyst. It's hard to say with 100% certainty a benign mid-membranous lesion is a cyst until you go and expose it surgically and see that there's actual capsule there. The epidermal inclusion cysts have this white sort of cheesy material in it, and the mucus retention, it's more of a clear to a yellowish mucoid fluid. This is just an operative picture of a cyst, and you see the, I don't know if y'all can see my pointer here. You can see that oftentimes the epithelium is tinted up around the lesion, but you can still see the general outline of it. And the picture on the right shows after the incision is made for the microlaryngeal surgery, you can actually see the cyst capsule. It's fairly distinctive once you get in there. This is an example of a patient not long ago that had a mucus retention cyst that I removed. That's the after pic. Some cysts, the epidermal inclusion cysts, can have a sulcus associated with them, a pit that extends down to the cystic structure, sometimes even into the vocal ligament. We didn't talk about reactive lesion, and I wanted to throw it in mainly they're actually fairly common, and this is an example of, if you look on this vocal fold, the left vocal fold, in this case, that would be the dominant lesion. I'm not sure what that was. It could very well have been a mucus retention cyst or a polyp. But on the contralateral side, you see this indentation, and that's actually the reactive lesion. And sort of, it's been called, Clark Rosen called it a cup and a saucer, the lesion itself being a cup and the reactive lesion being the saucer. And this is not always how it presents, but you frequently see this with reactive lesions, the sort of saucer configuration. So we'll go into case number 3.
Can I ring a bell on that?
Yes, please do.
I'm just not a big fan of the reactive lesion. You know,
Your name was on the paper of the nomenclature paper. You realize that, right?
I do realize that. I think it's all a continuum of vocal fold tension, closure forces, and airflow. I don't necessarily think it's the lesion on one side that causes the lesion on the other side. Like in that cyst case you showed, there was a small lesion on the other side. My way of thinking is the patient traumatizes both sides of the vocal folds with a hyperfunctional voice mechanism that's slightly inefficient, and they get bilateral changes. One develops more into a polyp, the other more into a cyst.
It's a very reasonable way of looking at things. And that's the problem with the nomenclature system is we have so many limitations. As you suggested, you know, we're trying to put some sort of framework to a problem that's really sort of difficult to completely define. It's amorphous in many ways. Some, like the lesions, the nomenclature system can be that way as well. So you bring up some very good points. So in this case, a 38-year-old male with 4-month history of dysphonia. He's a middle school, high school football coach. That has to be a tough job. His vocal hygiene is, let's just go ahead and say, awful, beyond poor. It's awful. No amplification. The school doesn't provide it for him, of course, Sarah, right? And his VSI 10 is 29. And his clinic visit when we saw him was in early December. Merry Christmas. So this is him.
Rainbow is a division of white light into many beautiful colors. These take the shape of a long round arch. Rainbow is...
All right. So Sarah, what comments would you like to make about this slightly washed out video stroboscopy?
It looks like there's a right mid-membranous lesion, and I think there's diffuse fullness on the left. That covers the whole vocal fold, or is it just?
I can scroll through her a little bit.
Yeah, it looks like on that abducted shot that there's diffuse fullness on the left. And that right lesion is impacting closure.
I agree. Mark, this just made me think, if I appreciate what you'd said about lesions being present frequently on both sides, but I guess I would say if all you did was remove this thing on the left, this fullness, let's just say it was fibrous, let's just say it's fibrous tissue. Do you really think the thing on the right would go away?
Oh, no, I don't at all. That's my point. That he's set himself up for chronic hyperfunction, which has led to changes bilaterally. They're slightly asymmetric in appearance, but they're all there. He's, you know, and if he didn't have that discrete lesion on the right side, he'd get better closure and he'd be less symptomatic.
I mean, I think, do you think
have a low-pitched rough voice?
Blake, do you think that are you implying by your question to Mark that if the right vocal fold lesion is removed, the left diffuse fullness is going to go away?
I am saying that's probably what's going to happen.
I would say it's the voice therapy that will make the left side go away, not the absence of the lesion on the right. And what you're doing is you're giving him, by taking that thing off on the right, you're giving him a more favorable glottic closure pattern so he doesn't have to push as hard, so he doesn't end up with as much shear, all right? But I don't think it's that right side that caused the left. It's the flow phonation, the stretch and flow that allows both vocal folds to heal.
And I agree. I mean, I think even if you don't take that right lesion off, that left side is going to get better with therapy. Absolutely.
And, you know, I'm sure this gentleman got, you know, think about what time of the year this happened. I'm sure he got plenty of voice therapy in this case years ago prior to surgical intervention. Everybody, all of our patients do that virtually that get this sort of thing. So yeah, and I certainly don't want to downplay the role of voice therapy in these patients. I think it's critical. I agree with everything you're saying. But after seeing that, questions for both. And I'm glad I had this slide the way it is, because I do clearly, this guy's a setup, it doesn't matter that he has a cyst. He's a setup for phonotraumatic lesions, whether or not you believe that was a mucus retention cyst that was going to happen anyway, or whether you convinced this is completely phonotraumatic. He needs voice therapy. You can't just remove this. He's in a bad setting that'll get him in trouble again. So clearly we agree on that. And this is a question really for both of you, because it does come up when specifically teachers, we're talking about teachers wanting surgery. And I'm sure both of you have had this happen where the teacher comes in, maybe it's in December or the spring semester is about to start, and they're like, can I get this done over spring break? What do you tell them if somebody said they've done voice therapy, they've improved, but that cyst is just as big as it was, and they say, I would like to get this done during spring break and I want to go to work 2 weeks later. I'll take an extra week off, 2 weeks.
For this patient, Blake, how long had this voice problem been going on?
Several months, 6-9 months.
Only months. I mean, if it were, my recommendation would be wait till summer.
What about you, Mark?
So I agree. I mean, the only time I would consider spring break is if we saw him in September at the end of football season, or the beginning rather of football season, and he agreed to change and did change, and we saw significant resolution. But even then, the reason he doesn't want it in summer break is he's going to start coaching again, right, in July or August.
Yeah.
So he doesn't really have a summer break. So that, I mean, I'd sort of take that into account. If he showed significant resolution because he was using his voice more efficiently over the winter, I would consider spring break, but not if he comes in January or February with a 6-month history. Are you following me? Am I making myself clear?
Oh, you are. Yeah, I mean, I hear everything you say. I don't know that I will operate on a teacher unless they have a full 2 or 3 months off.
Mm-hmm.
I've just been burned too many times, and so for me, it's summer pretty much in every case. There'd have to be a rare exception that we didn't. I just have been burned.
That's the point of pre-operative therapy, because if he's compliant, he can coach and be efficient. And I guess my point is his spring break, post-spring break may be less vocally demanding than his mid to late summer because of what happens in football season, right?
Absolutely right. I'm kind of assuming the summer is truly a time, and it is with most teachers. You bring up a good point about a coach, but with most teachers, as we know, they can usually take their summers off, and I always ask them that prior to planning surgery. Then I make sure they're not going to be teaching over the summer, but that's one of the few reliable times they have off.
We always started soccer practices August 1st,
Is there anything, this is debatable, anything unique or distinctive about the treatment of cysts versus, let's say, polyps and nodules? Right offhand, and I know, Sarah, you'd mentioned therapy for these patients pretty much is going to be very similar, but even maybe for their healing of patients that have cysts after microflap surgery, anything?
I think after microflap, I expect patients with cysts to be stiffer.
Okay.
For a longer period of time. So I think depending on how that presents itself, I always want patients to stretch post-operatively with pitch glides and sirens, but in a patient with a cyst, I probably address that a little bit more directly or more with more frequency.
Okay. Very good.
And I think the cyst is a bigger dissection. You showed yourself making an incision right near the cyst, but I think, you've got to get into that plane away from the cyst a little bit. And so it's a larger dissection. So I totally agree with Sarah. They tend to take longer to heal. Our medial microflap patients are back vibrating in 1 to 2 weeks routinely. You see that on their post-operative 1-week strobe, they're vibrating pretty nicely, but not so much with the cyst.
Yeah, I completely agree. And just again, for our speech pathology colleagues, I'll show you sort of just some fun little cyst. I did not edit this, so I'll have to drag through here a little bit. Some sort of cyst footage. This is not the same patient, but Mark, you probably don't like where I make my incisions. They're a lot more medial than probably you would be comfortable with. This is a mucus retention cyst that shows sort of grasping the epithelium there. It's got a spectacular part of this video that all the surgeons here will wince when they see it. But everybody's got their favorite dissection instrument. I love the Wu scissors. If Peak Wu were listening, I'd be so happy because his scissor is just fantastic. But this is a flap elevator. That's the lower part of the screen. And this is what I think you can do blunt dissection with a flap elevator. There's always fibrous connections, anterior and posterior, well, and in deep as well, that connect the cyst to the ligament. It can be a very tedious, wouldn't you say, Mark? Tedious.
Oh, yes.
These are really, I love them and I hate them at the same time. And this is showing some of these connective tissue bands between the cyst and the ligamentous tissue that you have to cut with sharp dissection. I try when I can. I don't always succeed to leave a little bit of tissue on top of the cyst, some fibrous tissue to grasp it with, and cut these fibrous connections. But the spectacular part, so this is showing we've got a lot of it shelled out, still cutting connective tissue here. And here's the part that everybody will wince. It looks like I'm gonna get a little aggressive with this thing. Trying to push it that way, and you'll see, there you go. There's the, moment.
But you can grab it still. You're around it 70%.
Right, so that's exactly what happens. So if you grasp this and try to close that off a little bit, you can actually, the dissection has to be really fast at this point, not as fast as I'm making it look here. But you can see I'm kind of rapidly trying to get this capsule off of the ligament, and it can get dicey making sure that you've removed everything. Unfortunately, this is going fairly well considering what I did to it.
Is there a hole in the flap there, Blake?
Yes, there's a hole in the flap.
Sorry.
Will you forgive me? You were my fellowship.
Well, that's why I like making the flap larger.
Have you ever made a hole in a flap?
Oh, yeah.
And this is it at the end. You see some fibrous tissue still connected to it, but I think fairly clearly I can see the
end of the cyst. Yeah.
And that gets snipped away there. Boom. And then,
Beautiful.
well, beautiful rupture. So this is him
The
after.
rainbow is a division of white light into many beautiful colors. These take the shape of a long round arch with.
How far post-op is this?
This is 3 months. Yeah, so I wouldn't show the 2 week, and you know why? Because it looked like a bomb went off. So they do, and I agree to your point, Sarah. I agree 100%. I think these take a lot longer to get their vibration back, and this is a good case. You know, I could show you a few that you know, the wave never really came back nearly as well as the other side. They sounded good, but just the dissection itself and the tenacity of the cyst made it, you know, left them with a less than ideal result. Ultimately, he went back to work. He did great. Happy for her. That's my favorite part.
We looked at that specifically, and when you start with no wave, like he did, you can restore the wave in about 80% of these patients, but you don't get the wave back in 100% of the patients. If you improve their closure, though, and the other side is still supple enough, then they do quite well.
Mm-hmm.
Yes, agree completely. Questions from the webinar audience, Laura?
Yes, we have quite a few good questions with this case. So one of them was, how do you decide when you're actually going to surgically excise a reactive lesion?
Oh, that is a great question. I will. So, well, Mark, why don't you answer first, and I'll give a different viewpoint.
So, if it's there when I take the patient to surgery, I take it off. I believe that the patients have done their best in voice therapy before I've gotten there, and
but you're about to make a better, you know, a better environment for the contralateral side once you remove that, though. Just as you.
But I disagree with that. I think that it's their hyperfunctional behaviors, which are bilaterally hyperfunctional, that create the lesions. So I don't think it's the left lesion creating the right lesion. I think it's the behavior creating both lesions.
So you're going to remove every single reactive lesion?
I'm going to remove a lesion. I don't believe there are such a thing as reactive lesions.
So they're bilateral lesions.
They're bilateral lesions. They were caused by the same bilateral hyperfunctional behavior.
I will say you're consistent, Mark.
If you're anything, you're consistent.
You cannot get him to change that script at all, can you?
No.
Yeah, so the contralateral lesion to that, if they're really small, I tend to leave them alone. And I think if it's firm, if you palpate it and it's firm, I'll be much more likely to remove it. We've KTP'd some of them, just nothing more than KTP, the reactive lesion. And I don't think anybody has, I am not aware of a paper that shows, really gives you a good information to decide what to do with reactive lesions. So it's all a judgment call.
So Blake, if you leave it there, does it go away postoperatively?
That's why I'm saying we should have a study to look at that. I believe they do, but I have never looked at that formally. I guess the way to ask yourself that anecdotally would be to say, can I think of patients where I left something there, the smaller lesion of the two phonotraumatic lesions, if I left it there and regretted it? That would be really the way to look at it. Oh, I wish I would have removed that. I had a chance. I was in the OR and I didn't. And I can't think of many cases like that.
I can.
I probably have I should ask my fellows, because they would know the truth. I have selective memory, Sarah, in case you're wondering. Any other questions, Laura? Questions? I kind of want to see if we can get to at least some of the last case.
Right. Well, there was another question as far as when you are counseling your patients before surgery. What kind of timeline do you give them to expect to go back to their normal voice?
Oh, that's a great question. Let me hear what you guys say. We may have 3 different answers. Keeping in mind, Sarah and Mark worked together for a while, so they may have infiltrated each other's heads at some point.
We can finish each other's sentences.
Okay.
But it depends what lesion is being excised. So can we clarify? Is there a cystic excision? I would say that they're. But I would say it's going to take a full 2 to 3 months for their voice to be back to where it's stabilized and they're feeling like they can.
I agree.
Yeah. Do what
but
they
a
want.
polyp, by a month, they should be back.
Yeah. I think for a polyp, I agree with you. If it's a superficial lesion, that by 4 weeks, people are feeling pretty good. Sometimes, depending on their level of preoperative strain, inability to release that. I think sometimes people still feel fatigue at a month, but they sound pretty good.
Okay, agree. Okay, let's see if we can get through some of this. I want to stop us at 8 o'clock. But this one kind of goes on for a while, so we probably won't get through all of it. But it's a 20-year-old female with a 2-month history of hoarseness in her speaking and singing voice. And she'd had voice therapy for nodules 3 years ago that she feels helped. We did not see her for that. Her main complaints were raspy tone, especially early in the day. She was a singing student. She lost over high end of her range, vocal fatigue, loss of projection. BHI 10 of 31 and a singing BHI of 80, so fairly high numbers. Let's go through we'll get some of the vocal hygiene stuff. Just forget about that now. Just look at her video.
The rainbow is a division of white light into many beautiful colors. Take the shape of a long round arc with its path high above and its 2 ends apparently beyond the horizon.
Go up on pitch and a little bit louder. Even louder. Can you go louder?
What are the odds Mark will determine there's bilateral phonotraumatic lesions
The rainbow
here?
is a division of white light.
100%.
All right, so Sarah, do you want to comment on this stroboscopy and what you see and sort of your impressions?
I think there's bilateral mid-membranous lesions, right greater than left. The right looks sort of on the lower lip medial edge to me, I think. And vibration is definitely reduced, I think, right greater than left.
Okay. Mark, do you have anything to add to that?
No, I think I would finish that sentence.
The clinical management, we agree she needs good vocal hygiene, voice therapy, right? This is clean up the larynx, we used to call it, or we still call it. Clean up the larynx, treat the cofactors, get her in some good voice therapy. She had voice therapy. She had pretty fairly significant reflux. Went back on her PPIs twice a day for 3 months. She stopped singing because her singing, and she was a voice major. I didn't tell you that part. And her vocal pedagogue says, you can't sing. Her voice is bad. Her singing voice is bad enough that he said you really need to stop singing this semester. Even though
her range, I can't imagine she could get very much in that range.
Yeah, exactly. After voice therapy, her voice did get better. She was able to sing with a quality voice, but she's still considering changing majors at this point. And you can see the results. Her VHI-10 went from 31 to 17, and obviously her singing VHI was still fairly impaired, but she was getting by okay. And this is her afterwards. And you'll hear Jill, our speech pathologist, ask her a question of, tell me the impressions of your voice now that you've finished a course of voice therapy. And this is probably after 6 to 8 sessions.
The rainbow is a division of white light into many beautiful colors. These take the shape of a long, round arc with it's less raspy. I don't know. It flows, I guess, a little better. Like,
so it's less raspy, it flows better, and that's what you get.
What kind of music is she singing?
It's been a long time since we've done this. It was not classical. I don't think. You would be surprised if it were, right?
Yes.
Any change, significant change? She feels better. Her vocal efficiency is without a doubt better. She can tell you that. In terms of just you don't have to put a name with it, Mark. I would never ask you to do that. But what do you think is going on now? Have you learned anything after that course of therapy in terms of categorizing, not with a name necessarily, but categorizing where this fits in your treatment algorithm at this point?
So the right side, I think, is quite a bit softer and better looking.
Mm-hmm.
And the left side with the vascularity now is more worrisome to me. It seems stiffer still.
You know, and would you agree that it's not unusual to see somebody with bilateral mid-membranous lesions that kind of shift over time and in different directions get better, then one side looks worse? And we've had some of these patients like her. Usually they're younger female singers where things just morph over time. And like I said, in different directions. And certainly
she's had an autoimmune workup and all of that stuff, right?
Yeah, it's negative. Yeah.
Okay. You know, it's the vascularity on the left vocal cord is more worrisome, but she's improving. So I'd encourage her to keep going because I still don't know what I'm going to operate on.
Yeah, yeah. Well, she's lost to follow-up for a while, and this is her several months later.
Is a division of white light into many beautiful
She's
colors.
still in college.
These take the shape of a long, round arc.
Well, I should point out that she had aphonic. She's always has these aphonic breaks, right?
Yeah, absolutely.
Yeah, she sounds stiff.
This is where I'd employ Dr. Rosen's trick of inspiratory phonation. I want to see if that right side unfolds when she goes.
What is she doing with her voice? She's not following directions.
She's highly social. She's highly social.
And when you hear her speaking, Sarah, she's not using fronted voice. She's not using, we talk about resonance, but I don't really know what that is. Resonance happens in many different places, but she's not using easy fronted placement.
Right.
Not very forward resonance.
So are you just sick of this now? Do you want her to do more voice therapy? Do you want to pull the trigger on this? What's the consensus of the group?
She's non-compliant with your recommendations. She's still using her voice inefficiently a lot of the time. If she wasn't, it would have stayed just as pretty as it looked 3 months or 6 months earlier than this.
Yeah.
So if you're telling me her autoimmune workup is negative, and I'm hearing her speak in a posterior tense voice, I'm concerned that that's what she's doing at the bar.
Right.
And honestly, if you operate on her and then send her to me, it's going to be a big fat pain.
Well, I don't like you, so that's exactly what I'm going to do. You want something done. So this came up, and I did treat her, and she'd worked with us a long time. Jill knew her very well. They actually had a good relationship and spent a lot of time working together, but did take her for a microflap at some point. I don't know how long after this it was. and I don't remember the timing, I'm sorry, but morphologically it was a polyp on the right side. I looked very carefully at the time I saw her, and I'll show you the photo, because again, this is a few weeks to months later, and things had changed again with her. I did not see a lesion on the left. She did have that varix that you talked about, or that ectasia. If I'd had the pulse KTP laser and I had her asleep, I probably would have used it. I didn't have my CO2 there either, Mark, sorry. But this is the sort of the before and after, and you can see her. This probably doesn't look as impressive on these pictures as it did on the video Strabowski. That's exactly what I saw, and that's before on top and after on bottom, obviously. And
so wait, what did you do to the left vocal cord? Nothing?
Nothing, absolutely nothing.
Why does it look so much better in the post-operative picture? Is it just the color?
It's probably the light on it. Yeah, I didn't do anything to it.
Okay.
So she's dyed her hair post-op, and this is her probably about, I want to say, maybe 4 weeks afterwards, 2 to 4 weeks afterwards. I'm sorry, I don't know all the dates.
The shape of a long round arc with its path high above and its two ends apparently beyond the horizon.
She's trained up her act.
You
She
did?
dropped a whip on her, man. I'm not going to take any credit for this.
You can take credit too.
So you put her on a week of voice rest.
That's correct. So, which we didn't really talk about, but generally for me, it's 5 days of voice rest. And then we have a handout we give them that's gradual return to full voice use, and that occurs over about, I want to say, about 3 weeks or so. And we give them a certain amount of time every day, and it increases. I imagine that's how you guys did it. I think I got that from Vanderbilt when I was there. It's a graduated increase in voice use, and she was under the care of our speech and language pathologist, and she did well. As you can see, she looks pretty good there, and she was fairly happy. It's early on, of course, and we know she still has her tendencies, her phonotraumatic tendencies.
Could you go back and let us hear her voice from this visit?
Absolutely.
Shows a division of white light into many beautiful colors. These take the shape of a long round arc with its path high above and its two ends apparently beyond the horizon.
Do you have a cold?
Yes. What did you hear in there? What were you noticing, Mark, there you wanted to hear there?
Well, I was looking to see if she had more frontal focus in her voice.
Sarah's shaking her head no.
No, because she's
Okay,
congested.
stop being a speech pathologist. You're not a good one.
No, I'm not. I said that's what I wanted to look for, but she
I
didn't.
think she's still not using great airflow. She's getting better closure, and she sounds smoother, but she doesn't. I mean, I'm not seeing her in therapy, and it's got to be tough. So I'm not faulting anybody for this.
No, Jill. Jill's the best.
Yeah, that's what I mean. I know. So,
So she finished voice therapy post-op and returned to school, and she felt her singing and speaking voice was great. At some point, she stopped being a vocal major, and I can't remember at what point that happened, but she, I think, was an education major after that. She still sang for fun, but it was not like going to be her career. Came off all her meds, and at her 9-month follow-up, which I'm about to show you, her BHI 10 was 1. Singing BHI 10 is 1 and RSI is 2. And I think that just her expectations of her voice had changed so much now that she changed majors. I think some of what you're seeing here with the change in her BHI 10s, I don't think it's so much what necessarily we did, but her, her own expectations of her voice. And this is interesting. And the reason I brought this up is for the exact reason that Mark talked about. People have these tendencies of phonotraumatic behaviors, and some people just never quite get out of that, right? We've seen all these patients like her who, despite surgery, despite voice therapy, and so here she is 9 months after surgery. She's very happy.
Of white light into many beautiful colors. These
Sorry, you didn't get more of her speaking voice. So what do you see? So what do you see there, Mark? Did I do the wrong
She's
thing?
liberalized her vocal behaviors. The left reactive lesion is
Still
back. And the right, on the lower lip on the right side, she's starting to form another polyp.
Yeah.
Yeah.
These are interesting patients. I mean, because you could just say this person's never going to get it. If I do surgery, it's ultimately going to fail. Or you could say that's a pretty big thing that needs to come off. And she's probably never going to have normal vocal folds, and I'm not going to make them normal. And the speech pathologist is not going to make them normal, but she's better. And this is somebody who I think, is not, this is ideal, but she did end up better off than she was. But those vocal folds will never be normal.
What happens, I would say, what happens if you would have put her on voice rest for 6 days and maybe even injected steroids into that right-sided polyp? I mean, it would have been cheaper, right? If you think about cost to society, is this contrarian, is this curmudgeon, or is this realist? I'm just thinking outside of myself. I've been in this exact situation because you've tried everything and the patient wants it. But I do think we need to start thinking 10 years down the line. We need to follow these patients out like this and see what they all really sound like 5 years after polypectomy. Did we really do anything? Is it good enough to remove a polyp and only give them better voice for a year?
To do that, Mark, you're going to have to stay at an institution more than 10 years.
I can't do that. I know.
But the other thing with her is she changed expectations, whether it's the work she did in therapy on her voice, whether it was what she did in voice lessons. If she had kept the same expectations of her voice, she would not be happy.
Right. I think you're right.
I do. And I also think this brings up my point about the reactive lesion. I don't know. I'll leave it.
I mean, it's still there.
Yeah. I don't know if we have any questions, but I think, what conclusions can you make from this? I think nomenclature will help us speak the same language. It's really interesting talking with you guys, because even after all this, and we wrote a paper together on this, Mark, we all have our different ideas of what to call things, and sometimes it's best not to call them anything. Phonotraumatic lesions. Mm-hmm. But what I've learned more than anything about taking care of these patients for 20 years is you can't do it by yourself. You need a good speech and language pathologist if you're an MD, and vice versa, a good surgeon if you're a speech and language pathologist to take care of these patients, because it requires a really collaborative effort on our parts. And
here.
Yay!
Yay!
So I think we're done. Allison, should we sign off?
Yeah, I can go ahead and end it. For the questions that weren't answered, we will get them sent to you, the responses sent. And at the end of the webcast, once you sign off, there is a quick questionnaire if you wouldn't mind filling that out.
Very good. Thanks, Allison. Thanks, everybody, for taking your time out of your day to come learn with us. Appreciate it.
Thanks, Blake. Thanks, Allison.
Thank you.
Here, guys.
Bye, Mark.
Bye-bye. Thank you.